Welcome to the Deep Dive. Today we're sharpening your clinical radar on a topic that, well, it truly embodies the art and science of nursing. We're looking at the intricate conditions that can profoundly impact pregnancy, labor, and the postpartum period. And this isn't about rote memorization, right? It's about understanding the ripple effect.
Exactly.
How one condition can sort of transform the entire perinatal journey, affecting both the parent and the newborn. We're really aiming to get you ready for those critical HESI and NCLEX style application questions. And maybe more importantly, for safe, compassionate, and truly informed practice out there.
That ripple effect you mentioned is precisely what makes perinatal care so dynamic, so challenging, but also rewarding. Pregnancy itself is just a time of immense physiological and psychological transformation. And while it's often a joyful journey, we know it's also a period where various medical and psychological conditions can emerge or, worsen. The crucial point here for nurses, for you listening, is that these conditions rarely exist in isolation. Their impact echoes across the entire continuum from conception right through the postpartum period, influencing both the parent and the new family.
That interconnectedness feels so key for us to grasp. Can you maybe give us a few vivid examples, like how one condition can lead to this cascade of effects?
Absolutely. Let's think about hypertensive disorders, like preeclampsia. It's so much more than just a high blood pressure reading, isn't it? This condition can severely compromise placental function, and that directly impacts fetal growth, potentially leading to preterm birth or intrauterine growth restriction, IUGR.
Okay, so the placenta is key there.
Definitely. Or consider gestational diabetes. A large for gestational age infant, which is a pretty common outcome, can really complicate labor and delivery.
Shoulder dystocia risk.
Big time. And then after birth, that newborn faces a significant risk of hypoglycemia. That requires immediate, sharp nursing intervention. You have to be ready for that.
Wow. So the mother's metabolic state directly dictates the challenges of birth and the baby's immediate health right after. What about the psychological side?
Yeah, that's huge too. Perinatal depression, for instance. It can deeply affect a mother's coping mechanisms during labor, making an already demanding experience feel, well, almost overwhelming. And critically, in the postpartum period, it can disrupt that healthy parent-infant bonding, which, has potential long-term impacts on family well-being and development. These connections really emphasize why understanding the whole picture, not just isolated symptoms, is absolutely paramount for nursing.
And that's really our mission today, isn't it? We want to help you not just differentiate these conditions, but truly anticipate their complexities, to apply evidence-based interventions effectively and, master client and family education. That teaching piece is huge.
Bro.
These are the critical skills you need, not just for exam success, but for becoming that truly impactful nurse.
So let's dive into our first set of conditions, focusing specifically on maternal physiology. All right, we're starting with a condition that sometimes gets dismissed, maybe as just bad morning sickness, but in reality, it's far, far more severe. Hyperemesis gravidorum, HG.
Yeah, it's vital for nurses to recognize that HG is an extreme, persistent form of nausea and vomiting during pregnancy. It's not the typical NVP, and importantly, it's a diagnosis of exclusion.
Meaning
We only confirm it after ruling out other potential causes for the vomiting. The key diagnostic features you'll look for are persistent vomiting not tied to other conditions, significant weight loss.
Yeah.
We're talking at least 5% of the pregnancy weight.
5%, okay. Yeah, and along with that, you'll often see ketonuria ketones in the urine. Electrolyte imbalances are common, particularly hypokalemia, sometimes alkalosis, and clear signs of dehydration and a fluid volume deficit. Sometimes, though less consistently, you might also see abnormal liver function tests or even thyroid abnormalities associated with it.
That sounds incredibly debilitating, just thinking about 5% weight loss and
Wow.
constant vomiting. How does HG impact the entire perinatal journey, starting right there in the pregnancy itself?
During the pregnancy, HG is often linked to elevated levels of hormones like HCG and estrogen. And unfortunately, psychological stress can exacerbate the symptoms, creating a difficult cycle. Risk factors include things like a prior history of HG, carrying multiple, sometimes even carrying a female fetus, or having hyperthyroidism.
Interesting.
And while rare, severe HG can lead to some really serious complications. Things like renal failure, esophageal rupture from the force of vomiting, and even Wernicke encephalopathy, which is a serious neurological disorder caused by thiamine deficiency. That's vitamin B1.
For the thiamine connection.
Critically, poor maternal weight gain from prolonged severe HG directly correlates with restricted fetal growth. The baby just isn't getting enough.
So even if the worst of the vomiting improves by, say, mid-pregnancy, that earlier impact can still cast a shadow on labor and beyond.
Precisely. Unresolved electrolyte imbalances, maybe significant malnutrition from severe HG, can really reduce a mother's stamina during labor. Makes sense, right?
Yeah, totally.
And dehydration itself can compromise uterine perfusion, the blood flow to the uterus and placenta. That can potentially lead to difficult labor progression or fetal distress. The ripple effect is really clear here. Early pregnancy complications can set the stage for later challenges.
And postpartum.
Postpartum, if maternal nutritional stores were severely depleted, recovery can be prolonged. It takes time to build back up. And these mothers also face a higher risk for postpartum anxiety, depression, or even PTSD related to the trauma of being so severely ill.
That makes sense. And for the baby.
For the newborn, well, if the HG was mild or moderate and the mother managed to maintain adequate nutrition somehow, outcomes are usually good. However, severe prolonged HG does increase the risk for things like low birth weight, the baby being small for gestational age, or even preterm birth.
Okay. So for us as nurses, this is where, the rubber meets the road. Assessment and intervention. What's the one thing above all else we need to zero in on for a client with HG throughout her care?
Okay, the absolute priority for nursing in HG is preventing and managing dehydration and those electrolyte imbalances. Full stop. You'll be meticulously tracking intake and output. Remember the goal. Urine output should be around 1 LLK-HR. Less than that, or a high specific gravity, say above 1.025, screams dehydration.
Got it. INO and specific gravity.
Yep, and watch for those clinical signs. Dry mucous membranes, poor skin turgor, tachycardia, maybe hypotension, concentrated urine. Daily weights are absolutely non-negotiable. Same time, similar clothing.
Consistency is key.
Totally. And checking urine ketones is important too. Their presence indicates the body is breaking down fat and protein for energy, basically. Starving. That's a red flag for inadequate intake. Lab-wise, you're monitoring the comprehensive metabolic panel, the CMP, looking closely at sodium, potassium, magnesium for those imbalances, and the complete blood count, the CBC, might show hemoconcentration.
Hemoconcentration. Explain that a bit.
Sure, it means the blood is more concentrated. Because there's less plasma volume due to dehydration, the red blood cells, hemoglobin, and hematocrit appear relatively higher. It's a key indicator of dehydration status.
Okay, that makes sense. So that's what we're assessing. What's the plan for interventions? How does it differ from outpatient to inpatient?
Right. So outpatient management usually starts with lifestyle and dietary tweaks. Small, frequent meals, avoiding spicy or fatty foods that trigger nausea. Sometimes things like ginger or acupressure can offer some relief. Pharmacologically, vitamin B6, pyridoxine, is often first line. Sometimes it's combined with doxylamine and antihistamine.
Like Decledgis or Bongesta.
Exactly. If those don't cut it, other options might include metoclopramide, diphenhydramine, maybe ondansetron. Steroids are usually reserved for really refractory cases and avoided before 10 weeks if possible.
And if they need to be admitted, for severe HG.
If severe HG requires inpatient care, a critical nursing action is to immediately make the patient NPO nothing by mouth.
NPO right away.
Yes, until the vomiting completely subsides. This is crucial to prevent further gastric irritation. Then, the priority is IV hydration with electrolytes. And here's a key point. Always administer thiamine before giving any glucose-containing fluids.
Why before?
To prevent Wernicke encephalopathy, giving glucose first can rapidly deplete the body's remaining thiamine stores in someone who's already deficient, triggering this neurological emergency.
Critical point. Thiamine before glucose.
Absolutely. Then you gradually reintroduce oral intake clear liquids first, then slowly advancing to bland, high-protein foods as tolerated. If someone really can't tolerate oral intake for a prolonged period, sometimes enteral nutrition via a feeding tube is considered. And total parenteral nutrition, TPN, is really a last resort due to its high risk of complications like infection and metabolic issues.
TPN sounds serious. What's the real practical insight into TPN safety beyond just the checklist stuff?
The critical insight for TPN safety beyond just checking boxes is understanding the potential for sudden, severe hypoglycemia if the infusion is interrupted. If that TPN bag runs dry and you don't have that bag of 10% dextrose ready to hang immediately, you're facing a crisis. It's not just, oops, ran out. It's a rapid drop in blood sugar.
So having D10W at the bedside is non-negotiable.
Absolutely essential. Along with the 2RN verification for orders and bag checks, using a dedicated central line, strict aseptic technique when handling lines and solutions, changing the solution and tubing every 24 hours. It all ties into preventing infection and metabolic chaos. And of course, constant monitoring of glucose levels, electrolytes, and daily weights is part of that safety net.
Okay, that's a lot on the physical side. But beyond that, how do we support these clients emotionally? They must be feeling awful, maybe even guilty or dismissed.
Emotional support is truly critical. You hit the nail on the head. Many clients with HG feel incredibly isolated, sometimes stigmatized, like people think they're exaggerating. It's so important to validate their symptoms, to really listen therapeutically without judgment. We should also be screening for depression and anxiety, which often accompany HG, and make referrals to mental health support when needed, and pointing them towards resources like the HER Foundation, the Hyperemesis Education and Research Foundation, can provide valuable education and a sense of community for clients and their families.
That validation piece sounds huge. Great, let's shift gears now to another major area, hypertensive disorders of pregnancy. This is a leading cause of maternal morbidity and mortality, right?
Tragically, yes. About 7 to 18% of pregnancy-related deaths are linked to hypertensive disorders.
And we're not just talking about high blood pressure numbers here. We're dealing with distinct clinical pictures, different syndromes, really, that demand different nursing responses.
Exactly. The basic definition of hypertension in pregnancy is a systolic BP of 140 millimeter Hg or greater, or a diastolic BP of 90 millimeter Hg or greater. But understanding the nuances between the categories chronic hypertension, gestational hypertension, preeclampsia with or without severe features, and eclampsia is fundamental for proper nursing care and anticipating the risks involved.
Okay, so let's unpack these categories. Maybe think of it like a progression of risk. Let's start with chronic hypertension.
Sure. Chronic hypertension is basically high blood pressure that was present before the pregnancy started, or it's diagnosed before 20 weeks of gestation. Or it could be hypertension that persists longer than 12 weeks postpartum. It might be primary essential hypertension or secondary to another condition. Key risk factors include things like advanced maternal age, obesity, diabetes, a family history of hypertension, maybe underlying renal or autoimmune disease.
And the big risk during pregnancy for someone with chronic hypertension.
The major concern is developing superimposed preeclampsia. About 25% of clients with chronic hypertension will go on to develop it. There are also fetal risks, like growth restriction or placental insufficiency, due to potentially compromised blood flow over time. Management involves frequent prenatal visits, close BP monitoring, checking urine for protein, nutrition counseling.
And medications.
Yes, medications like labetalol or nifedipine are often preferred. Hydralazine might be used for hypertensive crises. Diuretics are usually second line, maybe for pulmonary edema. Critically, ACE inhibitors are contraindicated during pregnancy but can be used postpartum.
Okay. And the key nursing action or insight here?
For chronic hypertension, the critical nursing action is teaching the patient to immediately report any signs or symptoms that could suggest superimposed preeclampsia. We're talking about headache, especially one that doesn't go away. Vision changes like spots or blurriness, right upper quadrant pain, or sudden significant swelling, particularly in the hands and face. Differentiating these from normal pregnancy discomforts is key.
Got it. So recognizing those warning signs early. Now, moving on to gestational hypertension, you mentioned this sounds like a working diagnosis.
It really is. Gestational hypertension is defined as new onset hypertension, again, 490 or higher, that appears after 20 weeks gestation, but crucially without proteinuria or other signs of systemic involvement like abnormal labs or severe symptoms.
So just a high BP after 20 weeks.
Right. It's considered temporary if it resolves by 12 weeks postpartum. If it doesn't, it gets reclassified as chronic hypertension. The challenge is that it can be really hard to distinguish early on from preeclampsia that just hasn't developed proteinuria yet. So the critical insight for gestational hypertension is to always treat it as a potential precursor, a condition that needs close watching. Why? Because about 15–25% of these clients will progress to develop preeclampsia.
Wow, up to a quarter.
Yeah. So management mandates vigilant monitoring, frequent BP checks, weight checks, urine protein checks, and lots of education on those preeclampsia warning signs we just talked about, plus ongoing fetal surveillance like kick counts or NSTs.
Okay, now for the big one, preeclampsia. What really sets it apart, and why is delivery the only definitive cure?
Preeclampsia is a pregnancy-specific multi-organ disease. It develops after 20 weeks gestation in a previously normotensive client. Classically, it's characterized by hypertension, that 490 threshold, and renal involvement, usually shown by proteinuria, 300 milligrams or more in 24 hours, or a +2 dipstick. However, the definition has evolved. You can also diagnose preeclampsia based on hypertension, plus new onset of other systemic findings, even without proteinuria.
Like what kind of findings?
Things like thrombocytopenia, low platelets, renal insufficiency, rising creatinine, impaired liver function, those elevated liver enzymes, pulmonary edema, or new onset cerebral or visual disturbances like severe headache or spots.
Okay, so it's systemic.
Very much so. And the absolute key insight that nurses must never ever forget is that delivery of the fetus and placenta is the only cure for preeclampsia. Management before delivery is about safety and trying to get the pregnancy further along if possible, but it doesn't fix the underlying problem.
And there's no magic pill to prevent it.
Unfortunately, no known medications reliably prevent preeclampsia, although low-dose aspirin for high-risk individuals is recommended. The incidence is around 5–8% of pregnancies. Risk factors are broad: being a first-time mother, age extremes, very young or over 35–40, black race, having chronic hypertension or diabetes already, multifetal gestation, even things like sleep apnea or a history of preeclampsia.
So let's get into the why behind the symptoms, the pathophysiology. How does preeclampsia cause such widespread problems?
The core issue seems to start with the placenta. There's abnormal development of the placental vasculature early in pregnancy. Specifically, the trophoblast cells don't invade the uterine spiral arteries properly. These arteries remain narrow and constricted instead of becoming wide, low-resistance vessels.
Okay, so poor plumbing to the placenta.
Essentially, yes. This leads to decreased placental perfusion and hypoxemia, low oxygen in the placenta. This placental stress is thought to release factors into the mother's circulation that cause widespread systemic inflammation and endothelial dysfunction.
Endothelial dysfunction, that leaky vessel lining again.
Exactly. The inner lining of blood vessels throughout the mother's body becomes damaged and leaky.
How does that manifest?
Well, plasma proteins like albumin leak out of the blood vessels into the surrounding tissues. This pulls fluid with it, causing generalized edema, swelling in the face, hands, legs. At the same time, because fluid has leaked out, the volume inside the blood vessels actually decreases intravascular hypovolemia. This makes the blood more viscous, thicker, which can lead to that hemoconcentration we talked about earlier, increased hematocrit. And on top of the leakiness, the blood vessels themselves become hyperresponsive. They clamp down generalized vasospasm. This further reduces blood flow to all the major organs.
Wow, so it's like a double whammy, leaky pipes and clamped down pipes. What happens to specific organs when this reduced perfusion takes hold?
Let's trace it. In the kidneys, decreased blood flow leads to a lower glomerular filtration rate, GFR. This causes BUN, creatinine, and uric acid levels to rise. The damage to the glomeruli also causes protein to leak into the urine, that's the proteinuria. Losing protein then lowers colloid osmotic pressure, worsening the edema.
Okay, kidneys take a hit. What about the liver?
The liver also suffers from reduced perfusion. This can cause hepatic edema, swelling, and even small hemorrhages within the liver tissue. This damage is reflected in elevated liver enzymes, AST, ALT. That epigastric or right upper quadrant, RUQ pain, is a really ominous sign. It suggests liver capsule distension or swelling and carries a risk of hepatic rupture. That's an emergency.
RUQ pain emergency. Got it. Brain.
In the brain, the vasospasm and endothelial damage can lead to small cerebral hemorrhages, ischemia, and edema. This manifests as symptoms like persistent headache, blurred vision, seeing spots or floaters. It also causes increased central nervous system irritability, leading to hyperreflexia and clonus, which are warning signs for potential seizures, eclampsia. In severe cases, you can see posterior reversible encephalopathy syndrome, or PRES.
Lungs.
Lungs. Capillary leakage in the lungs can lead to pulmonary edema, causing shortness of breath, dyspnea, crackles on auscultation.
And crucially, the placenta and fetus.
For the placenta and fetus, that decreased perfusion is the main problem. It can lead to intrauterine growth restriction, IUGR, fetal hypoxemia, low oxygen, acidosis, an increased risk of placental abruption, where the placenta detaches prematurely, and even stillbirth. Conditions like HELLP syndrome can also arise.
Understanding the pathophysiology really clarifies why the symptoms appear and why it's so dangerous. So what's the primary nursing focus, and what are the absolute critical interventions for preeclampsia?
Our nursing focus is constant vigilant assessment and early intervention. We are the frontline eyes and ears. We're meticulously monitoring blood pressure, assessing for proteinuria, tracking daily weights to monitor fluid retention, and strictly monitoring intake and output. Urine output less than 30 ml/h is a major red flag for worsening renal function or dehydration.
And neurochecks.
Absolutely. Assessing deep tendon reflexes, DTRs, and checking for clonus is key to gauge CNS irritability and seizure risk. Hyperreflexia +3 or +4, or clonus indicates increased risk. We're also asking targeted questions every assessment. Do you have a headache? any vision changes, any pain in your upper abdomen, noticing more swelling.
Key interventions.
Key interventions include maintaining seizure precautions, ensuring a quiet, low-stimulus environment, having padded side rails up per hospital policy, and having oxygen and suction readily available at the bedside. Administering magnesium sulfate intravenously as ordered is crucial for seizure prophylaxis. It's important to remember, magnesium sulfate is not an antihypertensive. It's given to prevent seizures.
Right, prevents seizures, doesn't lower BP directly.
Correct. We need to monitor closely for signs of magnesium toxicity. Always position the client, preferably on their left side, to maximize uterine perfusion. And patient education on reporting those warning signs immediately is vital.
You mentioned low-dose aspirin earlier for prevention.
Yes, for clients identified as high risk for developing preeclampsia, like those with chronic hypertension, history of preeclampsia, diabetes, etc., initiating low-dose aspirin, usually 81 mg a day, between 12 and 28 weeks, gestation is currently the most effective, proven preventive intervention. Calcium supplementation might also be considered for some. Things like vitamin C or E haven't shown benefit.
How do we differentiate between preeclampsia without severe features and preeclampsia with severe features? And what triggers an immediate escalation from the nurse?
Right. Preeclampsia moves into the with severe features category based on specific criteria hitting critical levels. The big one is severe range blood pressure. Systolic EO 160 mm Hg or diastolic EO 110 mm Hg confirmed on 2 readings taken at least 15 minutes apart while the patient is resting.
Okay, 160, 110.
Yes. But it's not just the BP. Other severe features include thrombocytopenia, platelets 100,000 Dell, impaired liver function, liver enzymes elevated to twice the normal concentration, or severe persistent RU epigastric pain unresponsive to meds. Progressive renal insufficiency, serum creatinine 1.1 milli-GDL or doubling of baseline, new onset pulmonary edema, or new onset cerebral or visual disturbances like severe headache, spots, blindness.
So any one of those pushes into severe features.
Exactly. The critical nursing action here is prompt treatment of severe range BP, usually within 30-60 minutes of confirmation, using IV antihypertensives like labetalol or hydralazine or rapid-acting oral nifedipine. And you absolutely must escalate immediately to the provider for any report of RUQ or epigastric pain, any new neurological symptoms, or signs of pulmonary edema like shortness of breath or falling O2 sats. These are emergencies.
Got it. Let's talk more about magnesium sulfate. It's a cornerstone for seizure prevention in severe preeclampsia. How do we assess for magnesium toxicity? What are the signs and what's the antidote?
Assessing for magnesium toxicity is an absolutely critical nursing responsibility whenever a patient is on a magnesium infusion. It's a CNS depressant, so we're looking for signs of too much depression. Key signs include respiratory depression, rate 12 breathsmen, falling oxygen saturation, loss of deep tendon reflexes, DTRs becoming absent or zero, oliguria, urine output dropping below 30 mL/HR, indicating poor renal clearance of the mag, sudden hypotension, and altered mental status or lethargy.
Absent reflexes are a big warning sign.
Huge. Going from brisk reflexes +3/+4 to absent 0 is a major red flag for toxicity. If you suspect toxicity, the immediate nursing actions are crucial. First, stop the magnesium infusion immediately. Second, support the airway, ensure adequate oxygenation, maybe call a rapid response. Third, notify the provider stat. Fourth, anticipate an order for a stat serum magnesium level.
And the antidote.
The antidote, which you must always have readily available at the bedside for any patient on magnesium sulfate, is calcium gluconate. The standard dose is 1 gram IV, which is typically given as 10 milliliters of a 10% solution, administered slowly over about 3 minutes.
Calcium gluconate, 1 gram IV slow push at the bedside.
Non-negotiable. Critical nursing actions also include performing an independent double check of all magnesium orders, calculations, and pump settings with another RN at initiation and with any changes. Keep that calcium gluconate literally at the bedside. And remember, during labor, if magnesium and oxytocin are running simultaneously, they must be on separate IV lines and pumps with careful monitoring of fluid intake. Postpartum, the seizure risk persists, usually for 24-48 hours, so the magnesium infusion is often continued. And a reminder, avoid methergine, methyl-ergonovine, for postpartum hemorrhage in any client with hypertension or preeclampsia, as it causes vasoconstriction and can dangerously spike their blood pressure.
Good point about methergine. Okay, what if, despite magnesium, the worst happens and preeclampsia progresses to eclampsia, the seizure itself? What are the immediate nursing priorities during and after the seizure?
Eclampsia is the onset of generalized tonic-clonic seizures in a patient with preeclampsia. It's a true obstetric emergency. During an active seizure, the immediate nursing priorities are: first and foremost, stay with the client and call for help. Immediately hit the call bell, yell for assistance. Second, ensure patient safety, protect them from injury, lower the head of the bed, clear the immediate area, maybe gently turn them to a lateral position if possible during the seizure to help maintain airway patency, but don't force it or restrain them. Padded side rails should already be in place.
Protect the airway.
Yes. As soon as the tonic-clonic movements stop, the priority shifts to airway management. Position them laterally to allow drainage of secretions. Suction the oropharynx as needed. Apply oxygen, usually 10 LN, via a non-rebreather mask. You also need to note the time the seizure started and ended and describe the characteristics of the seizure. Anticipate transient fetal heart rate changes like bradycardia or late decelerations during and immediately after the seizure due to maternal hypoxia. And anticipate administering a bolus of magnesium sulfate or initiating it, if it wasn't already running, per protocol or provider order to prevent recurrence.
So airway, oxygen safety, magnesium.
Exactly. And the critical nursing action from a preparedness standpoint is ensuring that oxygen and suction equipment are set up, functional, and checked at the start of every shift for any patient at risk, and making sure magnesium sulfate and calcium gluconate are immediately available on the unit or at the bedside.
Okay, let's briefly touch on a really dangerous variant, HELLP syndrome.
Right. HELP syndrome stands for hemolysis, elevated liver enzymes, and low platelet count. It's a life-threatening complication, usually considered a severe form of preeclampsia, but sometimes it can occur on its own, even without significant hypertension or proteinuria.
So it can be sneaky.
It can be. It typically occurs in the third trimester, or, importantly, can develop postpartum. The pathophysiology involves microangiopathic hemolytic anemia. Red blood cells get fragmented as they pass through damaged vessels. Hepatic injury due to obstruction of blood flow leading to liver cell damage and enzyme elevation. And thrombocytopenia from platelet consumption at sites of endothelial damage.
And the hallmark symptom.
The most prominent and concerning symptom is often severe RUQ or mid-epigastric pain, sometimes radiating to the back or shoulder. This indicates liver distension or even subcapsular hematoma. Nausea, vomiting, malaise, headache, and visual changes can also occur. There's a high risk of liver rupture or hemorrhage.
So that RUQ pain is even more ominous here.
Absolutely. Critical nursing action. RUQ pain in the context of potential HELLP syndrome is a major red flag, needing immediate escalation and investigation. Hepatic rupture is often fatal. Management is intensive care. Stabilizing the mother, administering magnesium for seizure prophylaxis, controlling severe hypertension carefully, cautious fluid replacement, potentially giving steroids like dexamethasone, which might help platelet counts, and fetal lung maturity if delivery isn't immediate and gestation is 34 weeks, and replacing blood components like platelets if needed. Delivery is usually indicated promptly once the mother is stabilized, especially if, 34 weeks.
Wow. Okay, let's transition now to a different kind of maternal-fetal interaction issue. Maternal-fetal blood incompatibility. This is where blood types can literally clash, right?
Exactly. It's a fascinating area where the mother's immune system, which is designed to protect her, can inadvertently identify fetal red blood cell antigens as foreign if they differ from her own. If she gets exposed to these fetal antigens, typically through tiny amounts of fetal blood entering her circulation, her immune system can produce antibodies against them. These antibodies, specifically IgG antibodies, are small enough to cross the placenta.
And then what happens?
They enter the fetal circulation and attack and destroy the fetal red blood cells that carry the foreign antigen. This process is called hemolysis, and it leads to hemolytic disease of the fetus and newborn, or HDFN.
Okay, and the primary concern historically and clinically is Rh incompatibility, right?
Yes. Rh incompatibility is the classic and often most severe example. It occurs when an Rh-negative mother, meaning she lacks the D antigen on her red blood cells, carries an Rh-positive fetus, who inherited the D antigen from an Rh-positive father.
And it harms the fetus, not the mother.
Correct. The mother isn't harmed by lacking the D antigen or by developing the anti-D antibodies. The problem arises for the fetus when those maternal antibodies cross the placenta.
How does the mother get sensitized or exposed in the first place?
Sensitization happens when Rh-negative maternal blood comes into contact with Rh-positive fetal blood. The most common time for this is during the delivery of an Rh-positive infant when placental separation allows fetal cells into the maternal circulation. However, it can also happen earlier in pregnancy due to things like miscarriage, ectopic pregnancy, abortion, invasive procedures like amniocentesis or chorionic villus sampling, or abdominal trauma. Once sensitized, the mother's immune system produces anti-D antibodies. These antibodies usually don't cause problems during the first Rh-positive pregnancy because the antibody production takes time.
But subsequent pregnancies are at risk.
Exactly. In subsequent pregnancies with an Rh-positive fetus, those preformed maternal anti-D IgG antibodies readily cross the placenta from early on and begin destroying fetal red blood cells. This leads to fetal anemia, which can range from mild to severe. The breakdown of red blood cells releases bilirubin, causing hyperbilirubinemia and jaundice in the newborn. In severe, untreated cases, the anemia can lead to heart failure, generalized edema, hydrops fetalis, neurological damage from bilirubin, kernicterus, and even fetal death.
That sounds devastating. So how do we prevent this sensitization from happening in the first place? This is where RhoGAM comes in.
Precisely. The cornerstone of prevention is the administration of Rho-D immune globulin, commonly known by the brand name RhoGAM. RhoGAM contains concentrated anti-D antibodies. When given to an unsensitized Rh-negative mother, these antibodies find any Rh-positive fetal cells that may have entered her circulation and destroy them before her own immune system recognizes them and mounts its own permanent antibody response. It essentially tricks her immune system.
So when is RhoGAM given?
Standard practice is to give a dose prophylactically around 28 weeks gestation to all unsensitized Rh-negative mothers. And here's the critical nursing action. If the infant is confirmed to be Rh-positive after birth, based on cord blood testing, the mother must receive another dose of RhoGAM, typically within 72 hours postpartum. This prevents sensitization from the exposure during delivery.
Never delay or omit that postpartum dose if indicated.
Absolutely critical for protecting future pregnancies. RhoGAM is also given after any potential sensitizing event during pregnancy, like those I mentioned earlier, miscarriage, amnio, trauma, etc.
Okay, so prenatal screening is key. All pregnant clients get a blood type and Rh factor check at the first visit.
Yes. And Rh-negative mothers also get an antibody screen, often called an indirect Coombs test. If it's negative, she's unsensitized, and she'll get the 28-week RhoGAM and postpartum RhoGAM if the baby is Rh-positive. If the antibody screen is positive, it means she's already sensitized, unfortunately. RhoGAM won't help at that point. The focus then shifts to closely monitoring the fetal condition for signs of anemia using serial antibody titers. Specialized ultrasounds, like Doppler assessment of the middle cerebral artery flow velocity, and potentially percutaneous umbilical blood sampling, PBS, or even intrauterine transfusion in severe cases.
As nurses, we'll be explaining this to families. What are the key points we need to make sure they understand? Like, why do they need a shot if they feel fine?
Great question. Clients often ask, what does Rh negative mean? We explain it means their blood lacks a specific protein, the D antigen. How can I be Rh negative and my baby Rh positive? We explain it's inherited from the father. What is sensitization? Exposure to Rh-positive blood causes the body to make antibodies. Do these antibodies harm me? No, they don't harm the mother. Why is RhoGAM necessary? It prevents their body from making those permanent antibodies that could harm a future Rh-positive baby. Highlighting the protection for future pregnancies is key. Why is the next fetus jeopardized without RhoGAM? Because if they become sensitized, their antibodies will be ready and waiting to attack the next Rh-positive baby's red blood cells. Explaining it clearly and calmly is crucial.
That's helpful. What about ABO incompatibility? Is it as common or severe?
ABO incompatibility is actually more common than Rh incompatibility, but it's usually much less severe. It typically occurs when the mother has blood type O and the fetus has blood type A, B, or AB. People with type O blood naturally develop antibodies, anti-A and anti-B, even without prior exposure to incompatible blood, likely from exposure to similar antigens in food or bacteria. While some of these antibodies are IgM, which don't cross the placenta, type O individuals also produce IgG forms of anti-A and anti-B, and these can cross the placenta and cause some hemolysis of fetal red blood cells if the fetus is type A or B.
So what's the main effect we see in the newborn?
The main consequence is usually mild to moderate jaundice or hyperbilirubinemia appearing in the first 24 hours after birth. Severe anemia, like in Rh disease, is rare. The critical nursing action here is recognizing that all newborns of type O mothers are at increased risk for jaundice. We need to screen them closely, often checking cord blood for the baby's blood type and a direct Coombs test, which detects maternal antibodies attached to the baby's RBCs, and follow hospital protocols for bilirubin monitoring and potential phototherapy.
Okay, so screen all babies of type O moms for jaundice. Good tip. Let's transition again, this time to diabetes mellitus in pregnancy, another really significant metabolic challenge.
Absolutely. Diabetes is fundamentally a chronic disorder of carbohydrate metabolism, resulting from either insufficient insulin production or the body's inability to use the insulin it produces effectively. That's insulin resistance. Without adequate insulin action, glucose can't get into the cells for energy, so it builds up in the bloodstream, causing hyperglycemia.
Lead into the classic signs of
Exactly. Polydipsia, excessive thirst, polyuria, excessive urination, and polyphagia, excessive hunger. The body starts breaking down fats and proteins for energy instead, which can lead to weight loss and the production of ketones, potentially causing diabetic ketoacidosis, DKA. Long-term uncontrolled diabetes damages small blood vessels throughout the body.
how does pregnancy itself throw a wrench into this whole glucose regulation system? How does metabolism change?
Pregnancy creates some really profound shifts in maternal metabolism, almost designed to ensure the fetus gets enough fuel. It's often called a diabetogenic state. In early pregnancy, roughly the first trimester up to 20 weeks, maternal metabolism changes slightly. Estrogen and progesterone stimulate the pancreas to increase insulin production. This, combined sometimes with nausea and vomiting-reducing intake, can actually lead to lower maternal glucose levels and increased risk of hypoglycemia, especially for women with pre-existing type 1 diabetes. The body also starts storing fat.
Okay, so risk of lows early on. What happens later?
In late pregnancy, from about 20 weeks onward, things really shift. Placental hormones, particularly estrogen, progesterone, and human placental lactogen, HPL, surge. These hormones create a state of insulin resistance in the mother's body.
Why does the body do that? Sounds counterintuitive.
It's thought to be an adaptive mechanism to ensure a continuous supply of glucose across the placenta to the growing fetus, which relies primarily on glucose for energy. The mother's cells become less sensitive to her own insulin, leaving more glucose circulating for the baby. Normally, the mother's pancreas compensates by increasing insulin production even further, sometimes 2 to 4 times the pre-pregnancy level.
But if it can't keep up,
If the pancreas cannot adequately compensate for this late pregnancy insulin resistance, the mother's blood glucose levels rise, and that's when gestational diabetes mellitus, GDM, develops.
so pregnancy is like a metabolic stress test.
Exactly. It unmasks an underlying predisposition to insulin resistance or insufficient insulin secretion.
What happens postpartum?
After delivery, once the placenta is out, those placental hormones disappear rapidly. Maternal insulin sensitivity usually returns to normal quite quickly, often within hours or days. Insulin needs plummet. Breastfeeding also tends to improve insulin sensitivity. Most clients with GDM will return to normal glucose tolerance postpartum. However, and this is a critical nursing point, having GDM significantly increases their lifetime risk of developing type 2 diabetes later on. Up to 70% may develop it within 15-20 years.
Wow, 70%.
Yeah. So the critical nursing action is that all GDM clients need thorough discharge teaching about this future risk, the importance of lifestyle modifications, diet, exercise, weight management, and the need for regular follow-up glucose screening postpartum and throughout their lives.
Okay, briefly, how is diabetes classified in pregnancy?
We generally talk about type 1 diabetes, autoimmune destruction of pancreatic beta cells leading to absolute insulin deficiency. Type 2 diabetes, predominantly insulin resistance with relative insulin deficiency. And gestational diabetes, GDM, which is carbohydrate intolerance first diagnosed during the second or third trimester. Sometimes you'll see White's classification used, especially for pre-existing diabetes, which categorizes it based on duration and presence of vascular complications. GDM itself might be subclassified as A1, diet-controlled, or A2, requiring medication.
And GDM is pretty common.
GDM occurs in about 2–10% of pregnancies in the U.S., with rates varying among different ethnic groups. And as we said, it's a major predictor for future type 2 diabetes.
Let's focus first on pre-existing diabetes, type 1 or type 2, being managed during pregnancy. Outcomes have improved, but risks remain high, right?
Outcomes have definitely improved dramatically with better management, especially preconception care. But yes, risks for both mother and fetus are still significantly higher compared to pregnancies without diabetes. Excellent glycemic control is absolutely paramount.
What are the major effects on the mother?
In early pregnancy, uncontrolled hyperglycemia during organogenesis, the first 8 weeks, dramatically increases the risk of spontaneous abortion and major congenital malformations. Later in pregnancy, mothers with pre-existing diabetes have higher rates of preeclampsia and other hypertensive disorders. They're also at risk for diabetic ketoacidosis, DKA, which can occur at lower blood glucose thresholds during pregnancy and can be precipitated by infection or missed insulin doses. DKA is a medical emergency for both mother and fetus. Polyhydramnios, excess amniotic fluid, can occur, possibly due to fetal hyperglycemia causing fetal polyuria. This overdistends the uterus, increasing risk of premature rupture of membranes, PROM, and preterm birth. Macrosomia, a large baby, typically 4,000 or 4,500 grams, is common if glucose control is poor. This increases the risk of shoulder dystocia during vaginal birth, birth trauma to both mother and baby, and cesarean delivery. Cesarean delivery itself carries risks, and diabetic clients may have poor wound healing. They're also prone to infections like UTIs.
Okay, significant maternal risks. What about the effects on the fetus and newborn? You mentioned congenital malformations early on.
Yes, the risk of congenital malformations is 2 to 6 times higher with poorly controlled pre-existing diabetes during that critical first trimester. Common anomalies involve the cardiovascular system, central nervous system, like neural tube defects, caudal regression syndrome, and skeletal system.
And fetal growth, can it go both ways?
It can. Macrosomia, large for gestational age LGA, is typical when maternal glucose is high, but her vascular system is relatively healthy. The excess glucose crosses the placenta, stimulating the fetal pancreas to produce excess insulin. Fetal insulin acts like a growth hormone, leading to increased fat deposition and organ growth. However, if the mother has significant vascular disease due to long-standing diabetes affecting blood flow to the placenta, the fetus may actually experience intratone growth restriction, IUGR, and be small for gestational age, SGA, despite maternal hyperglycemia.
So LTA or SGA, depending on placental perfusion, what are the major neonatal complications we need to watch for immediately after birth?
There are several critical ones. First and foremost is neonatal hypoglycemia. The fetus has been producing high levels of insulin in response to high maternal glucose. After birth, the maternal glucose supply is abruptly cut off, but the baby's pancreas keeps pumping out insulin for a while, causing their blood sugar to plummet rapidly. This requires close monitoring and early feeding.
Hypoglycemia is number one.
Absolutely. Others include hypocalcemia, hyperbilirubinemia due to polycythemia excess red blood cells produced in response to relative hypoxia, which then break down after birth, and respiratory distress syndrome, RDS. Fetal hyperinsulinemia seems to interfere with surfactant production, delaying lung maturity, even if the baby isn't preterm.
So the critical nursing point here is...
The critical nursing point, the take-home message, is that achieving and maintaining tight maternal glucose control before conception and throughout the entire pregnancy is the single most important factor in reducing both fetal and neonatal complications. Everything hinges on good glycemic control.
Okay. So how do we manage pre-existing diabetes during pregnancy? What's involved in assessment and treatment?
Ideally, management starts preconception with counseling and achieving optimal glucose control before getting pregnant. Assessment involves a thorough history, physical exam including baseline retinal exam, ECG, assessment for vascular or neuropathic complications, and key labs like HbA1c to assess long-term control, baseline kidney function tests, urine testing, and thyroid function. Fetal surveillance is intense. It usually starts early with ultrasounds for dating and viability, a detailed anatomy scan around 18-20 reps, often including a fetal echocardiogram due to the higher risk of cardiac defects. In the third trimester, regular fetal surveillance typically includes non-stress tests, NSTs, biophysical profiles, BPPs, serial growth ultrasounds, and sometimes Doppler velocimetry of the umbilical artery to assess placental function.
And the therapeutic management. What are the goals and key components?
The main goals are achieving euglycemia, normal blood glucose levels, fostering a healthy pregnancy outcome for both mother and baby, and preventing worsening of any maternal diabetic complications. It requires a team approach: OB, MFM specialist, endocrinologist, dietitian, diabetes educator, and the nurse. Key components include diet. An individualized meal plan developed with a registered dietitian is crucial. It usually involves a specific caloric intake based on weight and activity, balanced macronutrients, complex carbs, protein, healthy fats, spread over 3 meals and 2 to 4 snacks, including a bedtime snack to prevent overnight hypoglycemia and ketosis. Self-monitoring of blood glucose, SMBG. Frequent checking is essential, typically fasting and 1 or 2 hours after each meal. Target levels are generally strict during pregnancy. Fasting May 95 mg/L, 1 hour postprandial A 140 mg/L, 2 hour postprandial A 120 mg/L, and avoiding overnight levels below 60 mg/L, insulin therapy. Most women with pre-existing diabetes, especially type 1, will require insulin. Dosing often changes dramatically during pregnancy, typically decreasing in the first trimester due to increased sensitivity, then sharply increasing in the second and third trimesters due to rising insulin resistance. Multiple daily injections, MDI, using basal, long-acting like NPH or D-Tamir, and bolus, rapid-acting like Lispro or Aspart, insulin or insulin pump therapy, CSII, with continuous glucose monitoring, CGM, are common. Oral agents are generally not first line for pre-existing diabetes and pregnancy. Intrapartum management. During labor and delivery, glucose levels are monitored very closely, often hourly. The goal is usually to maintain levels between 80 or 110 milligdl to prevent neonatal hypoglycemia. This often requires an IV insulin drip alongside a dextrose infusion, carefully titrated. Postpartum management, insulin needs drop dramatically and immediately after delivery. Close monitoring is needed to prevent maternal hypoglycemia. Doses are readjusted based on pregnancy needs or breastfeeding status.
So, lots of monitoring and adjustment. The critical nursing point during labor and postpartum seems to be watching for lows.
Absolutely. Monitor closely for hypoglycemia during labor due to exertion and NPO status, and immediately postpartum due to the rapid drop in insulin resistance in both the mother and the newborn.
And timing of delivery.
The goal is usually to reach term, 39 weeks, if maternal and fetal status allows. However, earlier delivery might be indicated if there's poor glucose control, worsening maternal vascular complications, preeclampsia, or signs of fetal compromise. Cesarean delivery is often recommended if the estimated fetal weight, EFW, is very large, say 4,500 grams, to avoid shoulder dystocia.
So the overarching critical nursing action for pre-existing diabetes.
It really comes back to reinforcing the importance of tight glycemic control before and during pregnancy. Nurses play a vital role in teaching and supporting self-monitoring skills, adherence to diet and insulin regimens, recognizing signs of hypoglycemia, and providing anticipatory guidance throughout this demanding journey.
Okay, now let's switch to gestational diabetes mellitus, GDM, the type first diagnosed during pregnancy. How do we identify it?
Right. GDM is defined as any degree of glucose intolerance with onset or first recognition during the second or third trimester of pregnancy. Universal screening is recommended for all pregnant clients, typically between 24 and 28 weeks gestation, earlier if they have significant risk factors like obesity, prior GDM, strong family history.
And how is the screening usually done?
The most common approach in the U.S. is the two-step method. Step 1 is the glucose challenge test, GCT. The client drinks a 50-gram oral glucose solution, no fasting required, and blood glucose is checked 1 hour later. A value 130 or 140 milligdl, depending on the cutoff used, is considered abnormal and requires moving to Step 2. Step 2 is the oral glucose tolerance test, OGTT. This one does require fasting overnight, at least 8 hours. A fasting blood glucose is drawn, then the client drinks a 100-gram glucose solution. Blood glucose is then checked at 1, 2, and 3 hours after drinking the solution. GDM is diagnosed if 2 or more of these 4 values meet or exceed specific thresholds.
What are those thresholds for the 100-3K TT?
Typical thresholds are fasting at only 95 milligdl, 1 hour of 180 milligdl, 2 hour 155 milligdl, and 3 hour 140 milligdl. So 2 or more high values equals GDM diagnosis. There's also a one-step method using a 75-free OGTT, but the two-step is more common.
Okay. Once diagnosed, how do the effects of GDM compare to pre-existing diabetes?
The effects on the client, fetus, and newborn are generally similar to those of pre-existing diabetes, but with one key difference. Because GDM develops after the first trimester, the risk of congenital malformations is usually not increased, as organogenesis is already complete.
That's a relief.
It is. However, the other risks are still significant. For the mother, GDM increases the risk of developing preeclampsia and needing a cesarean delivery. And as we stressed, it carries a very high risk for developing type 2 diabetes later in life. For the fetus and newborn, the main risks are macrosomia, leading to birth trauma shoulder dystocia, neonatal hypoglycemia, hyperbilirubinemia, and potentially RDS, similar to pre-existing diabetes.
So management focuses on controlling glucose to minimize those risks.
Exactly. Therapeutic management for GDM starts with lifestyle modifications. Diet is the cornerstone, working with a dietitian for an individualized plan, usually involving carbohydrate control and distribution throughout the day. 3 meals to the 4 snacks. Limiting simple sugars is key, and that bedtime snack is really important.
Why specifically the bedtime snack?
The bedtime snack, typically containing both complex carbohydrates and protein, helps prevent overnight fasting, hypoglycemia, and, perhaps more importantly, ketosis. During the overnight fast, the fetus continues to draw glucose from the mother. If maternal glucose drops too low or reserves are inadequate, her body starts breaking down fat for energy, producing ketones. Ketones can cross the placenta and, if excessive or prolonged, may be associated with adverse neurodevelopmental outcomes for the fetus. So that snack helps maintain a steadier glucose supply and prevent ketogenesis. Critical nursing action. Always advise clients with GDM to eat their recommended bedtime snack.
Good explanation. What else besides diet?
Exercise is also important. Moderate activity like brisk walking for about 30 minutes most days of the week is usually recommended if no contraindications exist. Blood glucose monitoring. Self-monitoring is crucial, typically fasting and 1 or 2 hours after meals, postprandial. Postprandial checks are particularly important for preventing macrosomia as they reflect how well the body handles the glucose load from meals. The targets are usually the same as for pre-existing. Fasting 95, 1 hour 140, 2 hour 120. Pharmacologic therapy. If diet and exercise aren't sufficient to meet glucose targets, usually after a trial period of 1 to 2 weeks, medication is needed. Insulin is generally considered the treatment of choice because it doesn't cross the placenta and has a long safety record. Certain oral agents, like metformin and glyburide, are sometimes used off-label after careful counseling about risks and benefits, but insulin remains preferred by many experts. Fetal surveillance usually starts later than for pre-existing diabetes, maybe around 28-32 weeks, particularly if glucose control is poor or medication is required. This might include kit counts, NSTs, BPPs, or growth ultrasounds. Postpartum follow-up, this is essential. All women with GDM should be screened for persistent diabetes for 12 weeks postpartum, usually with a 75G OGTT. If normal, they still need screening at least every 1-3 years thereafter due to that high long-term risk. Lifestyle counseling is vital.
Nursing considerations for GDM seem heavily focused on education and support for these lifestyle changes.
Absolutely. Adherence can be challenging. GDM diagnosis can evoke fear, denial, frustration. We need to support them, use open-ended questions, provide clear rationales. Remember to provide all the normal pregnancy teaching too. GDM doesn't replace other aspects of prenatal care. Critical nursing actions include reinforcing why consistent blood glucose control matters for both them and their baby. We must teach the signs and symptoms of hypoglycemia, shakiness, sweating, pallor, irritability, headache, hunger, blurred vision, and how to treat it immediately. Usually 15 g of rapid-acting carbohydrate, like 4-ounce juice or glucose tabs, then recheck in 15 minutes. And constantly emphasizing the importance of that postpartum follow-up screening for type 2 diabetes is a key part of our role.
Okay, let's put this all together with the nursing process for any pregnant client with diabetes, pre-existing, or gestational. What does assessment look like?
Assessment is comprehensive. We need to evaluate the client's and family's understanding of the condition, the monitoring procedures, glucose testing, maybe insulin administration, the effects of diabetes on pregnancy, and their specific diet plan, including considering cultural or religious needs. Can they demonstrate the skills correctly? We need to assess their knowledge of hypo and hyperglycemia symptoms and management, review the schedule and purpose of fetal surveillance tests, and importantly, explore their emotional response to the diagnosis and the demands of management, anxiety, stress, coping mechanisms.
And recognizing those hyperglycemia signs is crucial, right?
Absolutely critical for safety. Hypoglycemia SS, shakiness, sweating, pallor, cold clammy skin, disorientation, irritability, headache, hunger, blurred vision. Critical nursing action. Treat immediately with 15G rapid carb, recheck glucose in 15 minutes, repeat treatment if still 70 mg/dL. If severe or unable to swallow, administer glucagon. Teach family members how to use glucagon. Hyperglycemia SS, polydipsia, polyphagia, polyuria, fatigue, flushed hot skin, dry mouth, rapid deep respirations, small if progressing to DKA. Fruity breath odor, late sign. Drowsiness, headache, maybe depressed reflexes. Critical nursing action. Notify the provider promptly. Assess for underlying causes like infection. Monitor closely for signs of DKA, especially in type 1. Ensure adequate hydration.
Okay. What are the common client problems or nursing diagnoses?
Things like knowledge deficit related to diabetes management, risk for unstable blood glucose level, anxiety or ineffective coping related to the diagnosis and complex regimen, risk for impaired maternal fetal well-being related to effects of diabetes.
And the goals or expected outcomes?
We want the client and family to be able to demonstrate self-care skills correctly, glucose monitoring, insulin injection if needed, develop and follow an appropriate meal plan, identify the signs and symptoms of hypo and hyperglycemia, and initiate correct management, verbalize understanding of the rationale for fetal surveillance, and utilize coping strategies.
Interventions to achieve those goals.
Interventions are heavily focused on teaching and reinforcement. Demonstrate skills, then have them return demonstrate. Acknowledge their anxiety and provide support. Self-monitoring BG. Teach proper technique for finger sticks, use of meter, recording results, timing of checks. Insulin administration, it's applicable. Review types of insulin, onset peak duration. Teach safe injection technique, usually 90-degree angle askew, rotating sites, injecting slowly. Remind them to eat within appropriate time frame after rapid-acting insulin. Critical nursing action in hospital. Always double-check insulin type, dose, and timing with another licensed nurse before administration. CGM insulin pumps. If used, review operations, site changes, calibration, troubleshooting, and specific pregnancy adjustments. Dietary management. Reinforce principles, carb counting or exchange lists, limiting simple sugars, emphasizing complex carbs, protein, fiber. Collaboration with a dietitian is key. Ensure they understand the bedtime snack rationale. Managing hypoglycemia. Reinforce the rule of 15. 15G carb, recheck in 15 minutes. Ensure they have glucose tabs or appropriate carb source readily available. Teach glucagon use. Managing hyperglycemia. Teach recognition of SS and stress the importance of notifying the provider, especially if ketones are present or illness occurs due to risk of DKA and fetal compromise. Teach infection prevention strategies, as infection can trigger hyperglycemia and DKA.
And evaluation. How do we know our interventions worked?
Evaluation involves seeing if the client support person can actually demonstrate the skills, if they've developed a workable meal plan, if they can verbalize the SS of abnormal glucose and initial management steps, and if they're keeping scheduled appointments for monitoring and follow-up. It's an ongoing process.
Okay, we've covered a huge amount on physiological conditions. Now let's shift our focus, as planned, to the broader, often deeply personal context of the childbearing family. This means looking at things like substance use, perinatal loss, and postpartum affective disorders, emphasizing that holistic, compassionate, and culturally competent care.
This transition is absolutely vital because these social and psychological factors are profoundly intertwined with physical health outcomes for both the parent and the baby. Substance use in pregnancy, for example, is such a complex challenge. We're talking about physical or psychological reliance on substances that affects the parent, the developing fetus, and the newborn, often with severe and potentially long-term consequences. Polysubstance use is also very common, which complicates things further.
And getting accurate numbers is tough.
Incredibly difficult. There's immense stigma and often a very real fear among pregnant individuals about potential legal repercussions or losing parental rights if they disclose substance use. This is a huge barrier to seeking and receiving care.
What are the most commonly used substances we see?
The most frequently used substances impacting pregnancy tend to be tobacco, alcohol, marijuana, and opioids, though others like cocaine and methamphetamines are also significant concerns.
Let's break down the impacts. What should nurses know about specific substances? Start with tobacco.
Tobacco. Smoking decreases appetite and can lead to poor maternal weight gain and nutrition. For the pregnancy, it increases risks of miscarriage, preterm labor, placental problems like abruption or previa, and premature rupture of membranes. For the fetus, it impairs brain and lung development, causes low birth weight due to reduced placental perfusion, vasoconstriction. Postnatally, infants exposed to smoke have higher rates of SIDIADs, respiratory infections, asthma, colic, even childhood obesity and bone fractures.
Okay. Alcohol, you mentioned this earlier.
Alcohol. The critical message here, which nurses must consistently reinforce, is that there is no safe amount, NO safe type, and NO safe time to drink alcohol during pregnancy. It readily crosses the placenta.
No, same level. Got it.
Alcohol use can cause preterm labor, miscarriage, and stillbirth. But the most devastating consequence is fetal alcohol spectrum disorders, FASD. The most severe form is fetal alcohol syndrome, FAS, characterized by prenatal and postnatal growth restriction, specific facial abnormalities like smooth philtrum, thin upper lip, small eye openings, and significant central nervous system impairment leading to intellectual disability, learning problems, memory issues, attention deficits, ADHD, and behavioral problems. Alcohol is the leading preventable cause of birth defects and developmental disabilities.
Marijuana. There's a lot of conflicting information out there.
Marijuana. Despite increasing legalization and perception of safety, marijuana use during pregnancy is not recommended and is associated with risks. These include potential for IUGR, increased risk of preterm birth, and possibly increased risk of stillbirth. THC, the active component, crosses the placenta and also passes into breast milk, raising concerns about its impact on infant brain development. Nurses need to educate clients that even if used for nausea, it's not considered safe during pregnancy or breastfeeding.
Cocaine.
Cocaine, a powerful CNS stimulant causing intense vasoconstriction, hypertension, and tachycardia in the mother. This dramatically increases the risk of placental abruption, spontaneous abortion, preterm labor, and precipitous, very fast delivery. Fetal effects include IUGR due to poor perfusion and potential for cerebral infarcts. Newborns may experience withdrawal symptoms, part of neonatal abstinence syndrome or NIS, feeding difficulties, and potential long-term learning and behavioral problems or vision issues.
Amphetamines, methamphetamines. Similar risks.
Amphetamines, methamphetamines, also CNS stimulants, similar maternal risks like hypertension and placental abruption. Fetal neonatal risks include congenital anomalies, low birth weight, withdrawal symptoms, poor APGAR scores, and potential long-term issues with memory and concentration in childhood.
Opiates. This is a huge issue with the current opioid crisis.
Opiates like heroin, oxycodone, fentanyl, also prescribed methadone, buprenorphine. Major maternal risks include overdoses, infections like HIV, Hep C from needle sharing, malnutrition, and poor prenatal care. Pregnancy risks include preterm birth and stillbirth. Fetal exposure leads to potential intermittent hypoxia, risk of meconium aspiration syndrome. The biggest concern for the newborn is neonatal abstinence syndrome, NAS, or neonatal opioid withdrawal syndrome, NOWS. These infants experience withdrawal symptoms after birth, like a characteristic high-pitched, inconsolable cry, irritability, poor feeding, tremors, sweating, vomiting, diarrhea, and sometimes seizures.
How is opioid use disorder managed in pregnancy?
The standard of care is medication for opioid use disorder, MOUD, typically using methadone or buprenorphine. These medications prevent maternal withdrawal, which is dangerous for the fetus, reduce cravings, block the effects of illicit opioids, and allow the mother to stabilize her life and engage in prenatal care. While infants exposed to MOD will likely still experience NASNOs, outcomes are generally much better than with continued illicit opioid use or attempts at medically unsupervised withdrawal during pregnancy. Managing NAS requires specialized care, often using non-pharmacologic soothing techniques, and sometimes medication like morphine or methadone for the infant.
What about prescribed medications, like SSRIs for depression?
SSRIs, antidepressants. This is different from illicit substance use. Treating maternal depression or anxiety during pregnancy is often crucial for the well-being of both mother and baby, and the benefits of SSRI treatment frequently outweigh the potential risks. However, some infants exposed to SSRIs late in pregnancy may exhibit mild, transient withdrawal-like symptoms, sometimes called poor neonatal adaptation. This can include jitteriness, irritability, poor feeding, or mild respiratory distress. It's usually short-lived and managed with supportive care. It's important to distinguish this from illicit drug withdrawal. Nurses need to provide education and surveillance for these potential effects.
So across the board with substance use, what are the key nursing considerations? It sounds like building trust and avoiding judgment is paramount.
Absolutely foundational. Our approach must start with universal, non-judgmental screening for substance use for all pregnant clients. Using validated screening tools in a private, confidential manner is best. We need to ask directly but empathetically. We also need to be aware of our state's mandatory reporting requirements regarding substance use in pregnancy, while also understanding how fear of reporting can be a major barrier preventing clients from seeking help. It's a delicate balance.
Connecting them to resources.
Yes, a key role is connecting clients who need it to appropriate treatment resources, like MOU programs, counseling, or social support services. Collaboration with social workers is often essential. We need to provide consistent education about the risks of substance use and the benefits of treatment, acting as an advocate for the client. And providing ongoing emotional support is crucial, recognizing the high risk of relapse, especially in the stressful postpartum period. We should also encourage and support breastfeeding when it's considered safe and appropriate. For example, it's generally encouraged for mothers stable on methadone or buprenorphine, as small amounts pass into milk, but may actually lessen the severity of NAS for the infant. However, breastfeeding is usually contraindicated with ongoing illicit drug use like cocaine or methamphetamines.
So the critical nursing action boils down to
Assess, support, educate, advocate, and ensure safety for both parent and infant. Early identification and referral, combined with a compassionate, non-judgmental approach, offer the best chance for improved outcomes.
let's apply the nursing process specifically to maternal substance use. How do priorities shift across the pregnancy continuum? Antepartum first.
During the antepartum period, assessment starts with that universal screening. We're also looking for subtle clues, maybe late or inconsistent prenatal care, missed appointments, poor grooming, inadequate weight gain. We need a good obstetric history and assessment of their emotional state. Are they angry, apathetic, defensive? A detailed, non-judgmental substance use history is key. Common problems identified might be knowledge deficit about effects, ineffective coping or inability to manage stress, perhaps feelings of guilt, denial, or fear. Desired outcomes include the client being able to identify harmful effects, verbalize feelings honestly, recognize personal strengths, and hopefully accept referrals for help. Interventions focus on building that trusting relationship. Provide clear health teaching, collaborate with social work and treatment centers, help them develop stress management strategies. It's important to praise small steps and positive changes. Supporting maternal fetal attachment can also be motivating. Evaluation is ongoing. Are they verbalizing increased knowledge? Engaging with resources, showing willingness to reduce or stop use.
Okay, what about the intrapartum period? Things can get intense here.
Yes. Assessment here focuses on recognizing signs of acute intoxication or withdrawal. For example, with recent cocaine use, you might see sweating, severe hypertension, tachycardia, perhaps hyperthermia, painful, intense contractions. Vasoconstriction can cause uterine irritability or abruption, dilated pupils. Fetal monitoring might show tachycardia or bradycardia or late decelerations indicating distress. With heroin or other opioid withdrawal, you might see yawning, runny nose, rhinorrhea, sweating, restlessness, dilated pupils, early withdrawal, nausea, vomiting, abdominal cramping. The priority problem is risk for injury to both the client and the fetus due to the physiological effects of the substance or withdrawal. Outcomes are focused on maintaining safety for both throughout labor and delivery. Interventions might include admitting with 2 nurses for safety if intoxication is suspected, setting firm, clear limits on behavior if needed, implementing seizure precautions for cocaine intoxication, using therapeutic communication, avoiding confrontational approaches. Managing pain effectively is crucial. Adequate pain relief can sometimes reduce substance craving. For opioid-dependent clients on MUD, it's critical to prevent withdrawal by continuing their methadone or buprenorphine dose and providing adequate additional analgesia. Avoid opioid antagonists like nalbuphine, ubane, or butorphanol, Stadol, as they can precipitate severe acute withdrawal.
Okay, postpartum. What are the priorities then?
Postpartum assessment includes monitoring maternal vital signs and level of consciousness for any signs of recent use or withdrawal. Critically, observe mother-infant bonding and attachment behaviors. Screen for relapse risk, which is very high postpartum due to stress, hormonal shifts, and potential loss of support structures. Assess their medical history related to substance use, for example, infections. Interventions focus on encouraging bonding and infant care participation. Support breastfeeding if appropriate and safe based on maternal status and substance use. Provide ongoing referrals for treatment and support groups. Social work and child protective services may need to be involved if there are concerns about infant safety upon discharge. We also need to address the emotional needs. Guilt, shame, low self-esteem are common. Evaluation includes assessing the client's understanding of ongoing risks, their willingness to continue treatment, and ensuring a safe discharge plan is in place for both mother and infant.
Are there general signs nurses should be aware of that might indicate substance use even if a client doesn't disclose?
Yes. While we must avoid assumptions, certain patterns can be red flags warranting sensitive screening. These include things like late or inconsistent prenatal care, frequently missed appointments, poor grooming or inadequate weight gain despite counseling, evidence of needle marks or nasal irritation, hostile or defensive interactions with staff, significant mood swings, or seeming apathy towards the pregnancy or infant care. Again, these aren't diagnostic, but they should prompt a non-judgmental assessment.
Okay, let's shift to another incredibly difficult topic, perinatal loss. This covers such a wide range from early miscarriage or ectopic pregnancy to stillbirth or neonatal death after birth.
And regardless of when it happens,
Right.
what truly stands out for nurses is recognizing how profoundly devastating this loss is for parents and families. It's a unique and often unseen grief. Parents often feel incredibly isolated. Their grief can be minimized or disenfranchised by society, sometimes even by healthcare providers, with comments like, well, you were only 8 weeks, or at least you can try again, or you have other children. These comments, however well-intentioned, can be deeply hurtful.
So our role is crucial in validating that grief.
Absolutely critical. Nurses are often the primary caregivers during the time of loss and immediately after. We play a vital role in acknowledging the reality and depth of their grief, providing compassionate, sensitive, family-centered care. Even very early pregnancy losses, like miscarriage or ectopic pregnancy, trigger intense grief responses that need acknowledgement and support alongside the necessary physical care.
What about situations where a loss is anticipated, like a lethal fetal diagnosis?
In those heartbreaking situations, perinatal palliative or hospice care becomes essential. The focus shifts from curative treatment to maximizing quality of life for the time the baby has, minimizing suffering, and supporting the family through their grief journey and complex decision-making. Nurses help families plan for both the birth and the anticipated death, honoring their wishes for that time.
And what about parents who become pregnant again after a previous loss? That must be a very different experience.
It's often filled with a complex mix of hope and intense anxiety, fear, or even symptoms of depression or PTSD. It's a critical nursing insight that having subsequent healthy children does not erase or lessen the grief from a past loss. Each child is unique. Parents might exhibit coping behaviors like delaying sharing the news of the new pregnancy, avoiding setting up the nursery or buying baby items, or being hypervigilant about every symptom or fetal movement.
How can nurses support them through a subsequent pregnancy?
Frequent prenatal contact, offering extra reassurance, even if medically everything looks fine, acknowledging and validating their fears without dismissing them, encouraging open expression of feelings, and offering referrals to specialized counseling or pregnancy after loss support groups can be incredibly helpful. The crucial point overall is that nurses must provide a safe space for grief, validate the parent's emotions regardless of the gestational age at the time of loss or whether they have other children, and proactively connect families with resources for ongoing support and healing.
How do we apply the nursing process specifically for a family experiencing pregnancy loss? What does assessment look like?
Assessment involves observing for common grief responses, which can vary widely. Crying, sadness, anger, guilt, withdrawal, numbness, difficulty concentrating, changes in sleep or appetite, poor hygiene. We should also be screening for signs of complicated grief, postpartum depression, or PTSD, especially in the weeks following the loss. Assess their existing support system partner, family, friends. A really important practical assessment point on the unit is communication. Use designated symbols on the patient's door or chart, like a falling leaf or specific sticker per unit policy, to alert all staff that this family has experienced a loss. This helps prevent insensitive comments or questions from staff who may not be aware.
That's a great practical tip. Priority nursing problems.
Often things like ineffective coping, grieving, altered family processes, risk for complicated grief, risk for spiritual distress, or risk for powerlessness.
And expected outcomes.
We hope to see parents beginning to express their grief openly, identify and utilize available support systems, and demonstrate initial coping strategies. Healing is a long process, but we aim to support the start of it.
Interventions. What can we actually do?
Key interventions include allowing expression of grief, create a quiet, private space, actively listen without judgment, avoid cliches, "It was God's plan, you'll have another one," or offering false reassurance, "Everything will be okay, just be present." Acknowledge their pain, acknowledging the infant. Use the baby's chosen name if they have one. Refer to the baby as your baby, your son, your daughter. Offer parents the choice to see and hold their baby, regardless of gestational age or appearance. Prepare them gently for what the baby might look like. Respect their decision if they decline. Creating memories. This is often incredibly important for grieving parents. Offer to take photos of the baby alone, with parents, with siblings. Offer footprints and handprints, a lock of hair, the baby's blanket or hat, a birth-death certificate if applicable. Create a memory box. Always respect cultural or religious preferences regarding these practices. Supporting siblings and family. Help parents understand how to explain the death to other children in simple, truthful terms appropriate for their age. Acknowledge the grief of grandparents or other family members too. Providing referrals. Offer information and connections to bereavement counselors, hospital chaplaincy or spiritual care, community support groups like Share or Resolve Through Sharing, genetic counseling if indicated, and follow-up medical care.
Evaluation.
Evaluation focuses on whether the parents were able to verbalize their feelings, participate in memory-making activities to the extent they desired, identify support persons or resources, and accept referrals for follow-up. We look for signs they are beginning to navigate the grief process, however painful.
Okay, finally, let's explore postpartum affective disorders, the spectrum of emotional challenges that can arise after childbirth.
This is another area where nurses play a crucial role in identification and support. We're talking about a range of mood disturbances that can occur after delivery, from the very common and mild baby blues to more severe conditions like postpartum depression, PPD, and rarely postpartum psychosis. It's absolutely crucial for nurses, families, and clients themselves to be able to differentiate between temporary adjustment changes and symptoms that are persistent, worsening, or significantly impairing function. Untreated postpartum depression in particular can have serious negative impacts on the parent's health, their ability to bond with the infant, and the long-term well-being of the entire family. The key message is, seek help if symptoms last longer than 2 weeks, if they interfere with daily functioning, or especially if they involve thoughts of harming oneself or the infant.
Let's start with the most common and mildest form, the postpartum blues or baby blues.
Right. The baby blues are extremely common, affecting up to 80% of birthing parents. They typically onset within the first few days after delivery and, importantly, resolve spontaneously on their own, usually within about 2 weeks. They're thought to be related to the rapid hormonal shifts after birth, plummeting estrogen and progesterone, combined with fatigue, sleep deprivation, and the emotional adjustment to parenthood. Symptoms include things like mood swings, feeling weepy or tearful for no apparent reason, irritability, anxiety, feeling overwhelmed, increased emotional sensitivity, and maybe some difficulty sleeping even when the baby sleeps. It's generally not considered a psychiatric disorder, but rather a transient adjustment reaction.
So nursing focus for baby blues.
Primarily reassurance and education. Reassure the parent and family that these feelings are very common and usually temporary. Encourage rest as much as possible, easier said than done. Self-care, accepting help from partner, family, friends, and good nutrition. Validate their feelings. The key education point is to instruct them to contact their healthcare provider if the symptoms don't improve after 2 weeks, if they get worse, or if they start having thoughts of harming themselves or the baby, as this might indicate progression to PPD.
Okay. When do the blues cross the line into something more serious, like postpartum depression, PPD? What are the hallmarks and risk factors?
PPD is a major depressive episode with onset during pregnancy, or more commonly, within the first 4 weeks to 6 months postpartum, though it can develop up to a year after delivery. It's significantly more severe and longer lasting than the blues, and it interferes with the parent's ability to function daily and care for themselves and their infant. It impacts bonding.
What puts someone at higher risk?
There are several known risk factors. The strongest predictor is a prior history of depression or anxiety, especially previous PPD. Other factors include being a first-time parent, significant hormonal fluctuations, medical problems during or after pregnancy, like preeclampsia, diabetes, anemia, thyroid issues, a family history of mental illness or substance abuse, low self-esteem, marital problems or lack of partner support, anger or ambivalence about the pregnancy itself, being single or very young, social isolation or lack of support, excessive fatigue and sleep deprivation, financial worries, stress related to childcare, especially with an ill infant, one with anomalies or a difficult temperament, having multiples, chronic life stressors, and having an unwanted or unplanned pregnancy. It's often multifactorial.
And the signs and symptoms nurses need to watch for, how might it present?
PPD symptoms are similar to major depression, but may have a postpartum context. Key signs include persistent feelings of sadness, anxiety, or hopelessness, overwhelming guilt or feelings of inadequacy as a parent, agitation or irritability, severe fatigue or lack of energy beyond normal postpartum tiredness, difficulty sleeping, insomnia, or sleeping too much, hypersomnia, changes in appetite, eating too much or too little, loss of interest or pleasure in activities previously enjoyed, and hedonia, difficulty concentrating or making decisions, excessive worry about the baby's health, or conversely, lack of interest in the baby, feelings of being overwhelmed, frequent crying spells, sometimes physical symptoms like headaches or stomach aches, and critically, recurrent thoughts of death or suicide, or thoughts of harming the baby. It's important to note that sometimes the parent might not initially present as sad, but more anxious or irritable. They may also be less responsive or interactive with their infant.
That sounds incredibly distressing. Nursing focus for PPD.
Our focus shifts to active screening, referral, and support. We should be screening all postpartum clients for depression using validated tools like the Edinburgh Postnatal Depression Scale, EPDS, both in the hospital and at postpartum follow-up visits. Encourage open communication and create a safe space for them to disclose their feelings without fear of judgment. Emphasize that PPD is a treatable medical illness, not a sign of weakness or bad parenting. Reinforce the importance of seeking help and following up with referrals. Referrals typically involve mental health counseling, psychotherapy, and potentially medication, antidepressants. Collaborate with the healthcare team regarding safe antidepressant options if the parent is breastfeeding. Connecting them with PPD support groups can also be very beneficial.
In the most severe form, postpartum psychosis. This sounds like an absolute emergency.
It is. Postpartum psychosis is the most severe but also the rarest form of postpartum psychiatric illness, affecting about 0.2% of births, 1 to 2 per 1,000. It typically has a dramatic and rapid onset, often within the first 2 weeks postpartum, sometimes even within days. It is considered a medical and psychiatric emergency. Features include signs of psychosis, hallucinations, seeing or hearing things that aren't there, delusions, fixed, false beliefs, often paranoid or bizarre, sometimes related to the baby, disorganized thinking and speech, severe insomnia, significant agitation or restlessness, rapid mood swings from depression to elation, confusion, and impaired judgment. The parent loses touch with reality. There is a significant risk of suicide and infanticide associated with postpartum psychosis due to the impaired judgment and potential command hallucinations or delusions involving the infant. It's often associated with an underlying bipolar disorder or a personal or family history of psychosis.
Nursing focus here is immediate safety. Immediate safety is the absolute priority. Nurses need to recognize these symptoms early. This is an emergency requiring immediate intervention. Ensure the safety of both the client and the infant at all times, which may mean supervised contact or temporary separation if risk is high. Facilitate immediate referral for psychiatric evaluation and typically requires inpatient hospitalization. Treatment involves antipsychotic medications, often mood stabilizers as well, and electroconvulsive therapy, ECT, can be very effective in severe cases. Ongoing family education and support are also crucial. What a comprehensive journey we've taken today. It's really covered a wide and critical landscape, hasn't it? It really has. From the, intricate metabolic demands of diabetes and pregnancy to the complex vascular changes of preeclampsia, the immune responses of blood incompatibilities, and then shifting to those profound emotional and social challenges of substance use, the deep grief of perinatal loss, and the spectrum of postpartum affective disorders.
And each condition, while it seems distinct, really underscores that intricate balance that's required for maternal and fetal well-being throughout the entire process. It's about seeing those threads, isn't it? How physical symptoms connect to deep emotional impacts, and how one small change can create ripples across the entire perinatal continuum.
Yeah. And your central role as a nurse throughout all of this seems just pivotal. That vigilant observation, the critical thinking skills, and the ability to intervene swiftly but also compassionately, those actions are often literally life-saving.
They really are.
And it's not just about the technical skills, right? It's not just administering medications or monitoring vital signs. It's also emphasizing the importance of clear client education, that crucial emotional support, and providing culturally sensitive care that really empowers families through what can be some of their most vulnerable times.
Absolutely. And as you, our listeners, synthesize this deep dive, maybe for your exams, maybe just for solidifying your future practice, it might help to focus on some key patterns for success. First, always ask yourself, how does pregnancy physiologically alter the specific medical condition? How does gestation shift the baseline risks and presentation?
Good point.
Second, understand the why behind the interventions and medications. Why magnesium? Why ROGAM? Why the bedtime snack and GDM? Remembering those critical nursing actions, those specific antidotes like calcium gluconate, that knowledge builds confidence and safety.
And knowing when to escalate.
Crucial, know when to raise the alarm, those red flags, those ominous signs like acute pain, severe headache, absent reflexes with magnesium, those are your cues for urgent action and communication.
And finally,
remember that holistic support. Your care truly extends beyond the physical tasks. It involves embracing and supporting the emotional well-being of the entire family unit, whether they're navigating a high-risk condition, grieving a loss, or adjusting to new parenthood.
so as you integrate all of this into your clinical wisdom, maybe here's a final thought to ponder. Beyond mastering the clinical protocols and the diagnostic criteria, how will you personally cultivate the wisdom and the empathy needed to navigate the nuanced, often unspoken challenges that families face during this time? How will you truly become that effective advocate, that trusted guide for individuals and their newborns, fostering not just physical health, but also resilience and hope, even when circumstances are incredibly difficult? That perhaps is the true art of perinatal nursing.